Thank you so much for the opportunity to be with you today to talk about a CABG update with regard to the revascularization guidelines. I have no relevant financial relationships. My only disclosures are that I am a coronary surgeon, and my comments are my own views and reflect my own clinical practice. A brief outline, we'll talk a little bit about the 2021 revascularization guidelines, a brief summary of the contemporary evidence from a surgeon point of view, and summarize. I've had the privilege to work with Dr. Tamis Holland and 24 other passionate AHA volunteers, including 2 patient members of the writing committee on the AHA-ACC 2021 revascularization guideline. This guideline will combine the 2011 PCI and 2011 CABG guidelines. There's an abundance of new data since these guidelines. You may see some of that data represented in the European guidelines, which are published in 2019. And our guideline is embargoed until publication, which will hopefully be this fall, so stay tuned. Patients who come for coronary revascularization with CABG mode tend to have diffuse disease, such as this image on the far left, with a distal left main lesion, a calcified left anterior descending that is occluded. In the middle image, you can see an occlusion of the left circumflex and a very calcified trifurcation. These patients often had reduced left ventricular ejection fraction, as you can see here. A heart team is important in evaluating such patients who are choosing revascularization type. In both the AHA guideline on the top and the current European guideline on the bottom, a heart team involvement is a 1C recommendation. When evaluating patients with a heart team, we consider all of these different factors, including the complexity of the coronary artery disease. But it is important to remember that the patient is also weighing the pluses and minuses of each revascularization strategy, and we must keep in mind his or her own personal preferences. Let's start with stable ischemic heart disease. On the left, you can see that CABG was a 2A to improve survival in patients with significant stenoses in 2 major arteries. In the European guidelines on the right, you can see CABG without left anterior descending stenosis is now a 2B. All other scenarios, revascularization of either type is a class of recommendation 1. What about multi-vessel disease? In the AHA guidelines, it was a 2A to improve symptoms to have CABG. And for 3-vessel disease with or without proximal left anterior descending involvement, CABG was a 1 or a 2A and PCI was a 2B. You can see in the more recent European guidelines that PCI is now a 1. This may have been influenced by the ischemia trial, which randomized patients to guideline-directed medical therapy versus an invasive strategy with patients with moderate ischemia. At a follow-up of 3.3 years, there was no difference in cardiovascular events or death. However, there were several limitations, and many surgeons feel that this trial was largely a trial of guideline-directed medical therapy versus PCI, as very few patients had CABG. What about acute coronary syndrome? This is one opportunity where PCI is often the revascularization strategy of choice due to the rapid timing. CABG is indicated if PCI fails or is not possible. Management of the non-culprit disease can be either with PCI or CABG, depending on the patient. What about left main coronary artery disease? On the bottom, the AHA guidelines, where CABG was a 1B and PCI ranged from a 2A to a 2B. Now, on the more recent European guidelines on top, you can see that low complexity left main disease is now a 1 for both PCI and CABG, and remains a 1 for CABG in all complexity categories. This is a very busy slide comparing all of the randomized controlled trials for left main coronary artery stenosis where patients were randomized to PCI or CABG. If you can highlight the second column, you can see the red circles indicate that in all of these trials, patients that were enrolled were equally suitable for PCI or CABG, so therefore likely to have less complex left main disease. This is a graphical abstract from the Gallo meta-analysis, which summarizes these trials well. Of the 5 largest enrolling trials with almost 5,000 patients, you can see on the first row here, all-cause mortality was not different between PCI and CABG for left main disease at 30 days, 1 year, and 5 years. At 5 years, myocardial infarction favored CABG, and the incidence of stroke favored PCI early on. Repeat revascularization favored CABG 1 and 5 years. What about diabetics? We know that the FREEDOM trial, which randomized patients to PCI with drug-eluting stent versus CABG for 3-vessel disease in diabetes with a follow-up of 3.8 years, had a 5-year reduced risk of MI death in CABG in the CABG group. And you can see that MI was 13.9% in PCI versus 6% in CABG. What about arterial grafting? You can see on the third row here that the use of radial artery recommended over saphenous vein in patients with high-grade coronary artery stenosis was a 2B in the American Heart Association guidelines on the right, and now in the European guidelines, it is a 1B. This is likely representative of multiple trials that have come out since that time. The ART trial was a very large trial, probably the largest in cardiac surgery, which randomized more than 3,000 patients to bilateral internal mammary versus single. There was no difference in mortality at 10 years in the intention to treat analysis. However, there was significant crossover, and a post-hoc as treated analysis demonstrated clinical benefit with multiple arterial grafting. This is a meta-analysis of multiple randomized controlled trials for radial artery versus saphenous vein, and this found that the incidence of adverse cardiac events was less in the radial artery group, including need for repeat revascularization and graft occlusion. This very large meta-analysis of more than 20,000 patients demonstrated longer-term mortality benefit in the radial artery group compared to saphenous vein. So in summary, this is a figure from the European guidelines, favoring PCI on the left and favoring CABG on the right. CABG is typically favored in patients with diabetes, reduced left ventricular ejection fraction, contraindication or non-adherence to DAT, and recurrent diffuse in-stent restenosis. In addition, complex coronary disease with high syntax score, anatomy likely to result in incomplete revascularization with PCI, heavily calcified vessels, and in patients undergoing concomitant cardiac surgery. Thank you so much for the opportunity to discuss an update on CABG with regard to the revascularization guidelines. Thank you.